Hi, good afternoon. This is Ann Greiner, and I'm the President and CEO of the Patient Centered Primary Care Collaborative. Welcome to you all this afternoon. You've joined a PCPCC webinar on the shared principles of primary care. We're so pleased that you'll be with us this afternoon. Let me introduce our speakers. The first to my immediate left is Christine Bechtel, and Christine has spent her career shaping both public policies and on-the-ground practices that result in better health and better health care. She's a well-known consumer advocate here in Washington, D.C., and a healthcare expert, having served in organizations like the National Partnership for Women and Families and AARP. Christine has a subject matter expertise ranging from health IT and quality improvement to patient and family engagement and performance measurement. She co-chairs both the shared principles. She co-chaired both the shared principles of primary care steering committee and the Patients, Families, and Consumer Center at the PCC. And then to Christine's left is Glenn Stream. He's a family physician practicing in La Quinta, California, and is past president of the American Academy of Family Physicians. He serves as the president and board chair of Family Medicine for America's Health. He earned his medical degree from the University of Washington School of Medicine in Seattle and completed his family medical residency at the Swedish Hospital Family Medicine Residency Program, also in Seattle. Glenn worked for 6 years in a 3-person rural family medicine practice in Kashmir, Washington. So Glenn has has run the gambit in terms of the kinds of practices he's worked in. And before joining the Rockwood Clinic, a large multi-specialty practice in Spokane in 1991. We're so pleased to have both Christine and Glenn join us today. And before we get underway with the webinar, just a couple of housekeeping. Please, when you're asking your questions, chat them into the box. We have hundreds and hundreds of people on the webinar today, and it would be difficult to have you raise your hand. So it really is the best way for us to answer your questions. And we do have some exciting content, and we're sure you're going to have questions about it. We'll also be taking a poll, so you'll have an opportunity to weigh in that way as well. So without further ado, let me get started. And here are our panelists that you just heard me speak about, Christine and Glenn. And now you can see their lovely pictures, not only in the webinar, but also on the slides. Okay, so the shared principles. Why don't we start with really a question. Let me first ask this of Glenn. And I think those of you who are joining know that there are 7 principles, and each of the icons are down the right-hand side of your slide deck. And we will be going into much more detail about the shared principles, but really want to first give some background and context. So Glenn, let me start with you. What would you say is the purpose of the shared principles?
Thanks, Ann. So from my viewpoint, the shared principles are really focused on defining what is the sort of culture and environment and values of the system that delivers primary care to people and families and communities. And once we can agree on that, then how do we leverage that sort of shared perspective into action about how do we work to achieve a healthcare system that embraces and embeds those values? We're facing challenging times in our healthcare system. We spend a lot of money, but we don't really get the return on investment that other first world countries get in terms of outcome of the health of their people. And to do better, we need to build on our primary care system. And to do that, I think we need these shared principles, a vision that all the key stakeholders, physicians, other clinicians that work in primary care, the people who pay for and fund care, including employers and payers, and most especially the patients themselves. They are the most key stakeholder in this, and I'm very grateful that their perspective was strongly included in the development of these shared principles.
Christine, what would you like to add to that? Thank you, Glenn.
Yeah, thank you. And thank you all for having me today as well. I agree with Glenn. I think the idea of really having a unifying vision that has some real depth and substance to it is a great tool for us to all rally around. It strikes me that, we're at a pretty unique time in our country. And so having a vision that is both achievable and aspirational and something that we can really unite around, something that we can use as a common ground lever point to really advocate for the healthcare system that we all want for primary care and for that care experience. To me, that feels really essential at this particular moment in history. So this, the shared principles, I think, reflects a lot of evolution that's happened over the past 10 years in particular. And this document was designed to help people see the patient-centered medical home model as really great primary care. We, I think, struggled for a long time with the name, particularly from a consumer perspective. The medical home being a place, and probably not a happy one at that, I think has been a challenge for people. And so having now what is this beautiful vision of great primary care, which is PCMH, but that's synonymous with great primary care, I think has been an important aspect. And the last thing I'd say is, and Glenn mentioned this, the idea that it can serve as a tool for all of us to align our work around, that to me is really important at this particular moment in history. Ed Webb said on one of our steering committee calls, he called it team-based advocacy, this idea that we could really come together and advocate for that vision, and using this shared principles as a tool, to me, is really exciting.
Thank you. Can you tell me a little bit about the history of the shared principles? I certainly, when I arrived at the PCPCC, so much of the work had already been done. So I'm really would love to know in more depth. And why don't we start with Glenn? What was the impetus behind them? Why did you all decide to work on the shared principles? What's the history?
Yeah, thanks, Anne. So just a very brief history about Family Medicine for America's Health, which is the organization I represent on this call. The work around this shared principles was a key part of the project plan for our project. So Family Medicine for America's Health is a 5-year collaborative project of 8 national family medicine organizations, really aligned to help primary care contribute to achieving the quadruple aim when we talk about clinicians having not just improved patient care and experience, improved health and cost savings, but also, very importantly, the joy and practice of our colleagues, again, not just physicians, but everyone who works in a healthcare environment. So our goal is to advance that. So in the creation of the project, we really felt like we needed to come together as family medicine organizations, and yet we certainly couldn't have the impact that we wanted to alone. And so we wanted to look for like-minded folks to collaborate around various pieces of our strategic work. And so this shared principles was a piece of work undertaken by our engagement team. And I want to give a shout out and recognition to Dr. Ted Epperly, who was our tactic team chair and a participant in the co-chair with Christine in the steering committee for this process, because he just put a lot of his heart and soul in that, and he's got a big heart. But a family doctor, past president of the American Academy, really took this as his charge and has moved that forward. So the history then is we recognize that as family physicians, this is not work that could, in reality or even in perception, seem to come only from physicians. So we look for a partner, and a stakeholder with multiple representations of stakeholders in the primary care space, and that naturally led us to the PCPCC. So, there's representation of patient advocate groups, of various clinician specialties, of employers and payers, really all the key stakeholders. And so they were a national partner and convener for us to to embark on the process that came to these shared principles. And I think Christine, as a key person in that process, can expand on that.
Yeah, so you mentioned Ted Epperly, and I want to just echo your thanks for his awesome leadership throughout this. It was so helpful to have a clinician really guiding the work of the steering committee, along with Julie Schills from Anthem. She's a senior VP at Anthem, and I love Julie. And her work to co-chair with us was really made for a really good, diverse set of voices in that guiding role. So we're grateful to her as well. And Julie and I had the privilege of co-chairing the accreditation work group for the PCPCC back in 2015. And I think that was for the PCPCC, the origin of the willingness to think about this adventure with FMA Health around the shared principles. And we've made a recommendation in that work group around really updating the attributes of the patient-centered medical home and thinking broadly about how PCMH fits in primary care, the notion of advanced primary care. We see, as Glenn just said, kicked off that collaboration, or what I call that adventure, with FMA Health early in 2016. So it's been well over a year that we've been, actually almost 2 years, I think now, that we've been at work on this with FMA Health. We have this awesome multi-stakeholder steering committee. I think, Anne, do you have the steering committee folks on a slide? I think you just showed it.
Yeah. Yeah.
So, you know, representation from all the different parts of healthcare, and it's such a great group to work with. We're so grateful for all of their input. We also had help from CFAR, from Mal O'Connor and Jason Ring, and then later Christian Carmen, who created a side-by-side comparison of 8 different sets of principles. We weren't starting with a blank page. You know, we know that. We built heavily on the work that had gone before us, including the joint principles. We created a public survey to invite open comment on the most critical concepts and their priority order. We had an in-person summit in November, around this time last year, to take those concepts, build out the actual principles. We started with the straw man, we went to the principles. So we had a second public survey, as well as the input and the leadership of the steering group. And then we just took input from anybody who wanted to provide it. So it was a beautiful collaborative effort that really received diverse input from many, many different voices in healthcare. And I think that was really essential to making them as complete as they are, and as broadly supportable as they have been on a consensus basis. So it was quite a process. I think it was early earlier mid-April of this year that the FMA Health Board and the PCPCC Board officially adopted them. And then we were able to work with Rosie Sweeney. Her leadership was tremendous throughout this as well, to get sign-ons and to have, you know, a continued public dialogue around these principles. And then, as you guys know, they were announced last month. So it's quite a history with quite an awesome group of people and organizations who contributed a lot of their best thinking to making them as great as they are.
Thank you very much. And I would also add the perspective of the PCPCC board. I mean, I think that when FMA Health came to the PCPCC board, the board was at the point of wanting to communicate to the field that you know, we saw this evolution beyond the patient-centered medical home to other models of advanced primary care, that we see that as a really, really important model, and we will continue to promote it. But as we know, there are other models that are developing in the field, and they also have value. And so I think what the shared principles does is broaden our lens, if you will, not just on, and very importantly, on, you know, what are the attributes of primary care that we're seeking, and, you know, what is that vision, but also that we're moving beyond one model as an organization. And so that this whole exercise was really important in that regard. And we were so pleased to be able to announce these shared principles at our most recent conference, and really we were so excited that we had 240 signatories over a very short period of time sign on to them, and we will, of course, continue to welcome others to sign on as well. So next question, how are the shared principles different than the 2007 joint principles in the patient-centered medical home? Glenn.
Yeah, thanks. Before I forget, I certainly want to acknowledge Julie as well. You know, anytime you're acknowledging people, you always leave out somebody, and so Julie shows his contributions very much appreciated. And I won't call them out individually, but on that steering committee, several members of my project team that I very much appreciate their work. You know, I had to actually this morning, I pulled out the shared principles from the joint principles from 2007 to remind myself. And I see a significant amount of overlap, but significant differences as well. And I think a lot of that has to do with the timing of those in 2007 versus our shared principles of patient-centered or primary care currently. You know, at that time, the concept of the patient-centered medical home was new, and its actual sort of structure and operations needed to be defined and communicated to people. And there were important pieces in there about the values and the culture. And I see this document really as in no way replacing those, but building on that important work that happened then, building on it in defining, again, those values and cultures about the environment in which care is delivered, the nature of the care experience that patients and their families and their caregivers find in the care they receive, that it's, and we'll go through the detail of these individual shared principles, but that it's culturally and linguistically sensitive, that it meets their values, it engages them in decision making. It just really expands very importantly on those sort of value things that are so important in primary care delivery.
So, Glenn, as soon as you said, oh, we always forget somebody, I had this lightning bolt and I feel so bad and so embarrassed. But I also do want to recognize the role that Marcy Nielsen played, because she organized the early work and spent, you know, a year of her life really figuring out how to pull this great stakeholder group together in the steering committee and supporting Julie and me as we worked with Ted as well. So, big kudos to Marcy. I just love the vision, and we're happy now to be able to have Anne at the helm as well. So the 8 principles, so I mentioned that we did a comparison of the 8 principles before us, including the joint principles. And I think, Glenn, you're exactly right. These don't replace the joint principles. They definitely build on them. And that was very intentional and very much by design. You know, I think from my vantage point as a consumer advocate, the joint principles were incredibly helpful for helping to more clearly define the operational level of the PCMH. But because they were also advanced by 3 physician organizations, 3 of any of the same type of stakeholder organizations, I think it led people to want to create their own set of principles from their own perspective. And that was certainly true for the consumer principles for the patient-centered medical home, which I worked on when I was at the National Partnership. And, you know, the funny thing was, I'll remember that Rob Dribbin, who is with Merck and on the he's a PCPCC executive member, I think. I'll probably mess that one up too. But I remember that he called me and he said, you know, y'all put out these consumer principles. Well, he probably didn't use the word y'all, but you put out these consumer principles, but are they really that different from the joint principles? And at the end of the day, you know, there were some areas of emphasis that were different, but they were much more in common than they were different. And I think that's true. In that many people then who issued their own set of principles may put their own voice on it, but that was really to me, that's one of the greatest assets of the shared principles, is this idea that it's now almost 250 different organizations who've said, yes, this represents our view from all walks of the healthcare life, consumers, oral health, dental health, behavioral health, you know, payers, purchasers, you name it. Of course, clinicians, physicians, NPs, PAs, you name it, right? So it's really this fabulous coming together. And I think that PCPCC over time has become that multi-stakeholder convener. And that was a very important role to be able to produce something like this, all the work that went into really convening and leading this multi-stakeholder process. So I think that, you know, conceptually, you know, there is an enormous amount of similarity, and symbolically to be able to have such a huge diverse group of people also promoting it has been really important for us.
Thank you. You know, as I read them, I did see that changes in the environment and also our expectations for medicine and for a sense of, and also changes in what we understand about the evidence really did affect the shared principles. And by that I mean, for example, in the shared principles, we have an emphasis on social determinants of health because of what we now know of how much that contributes to patient outcomes. And we really didn't have that 10 years ago, that evidence-based. And so I think that's reflected in the shared principles. I see a focus on value and this notion that we all need to be stewards of scarce resources. And that really, you know, is a principle that's called out. And I see that as a shift, you know, for our field. There's also, and I'd be curious what you think, Christine, you know, a much more robust understanding of how patients and families can be engaged in decisions about their care, and also can be engaged to help think through, you know, things like practice design. And so I think that also reflects how the field has evolved in really positive directions. And then finally, I think the team is called out even to a greater extent than it was in 2007. So I also see this evolution in some ways that really do reflect, you know, changes in our understanding of the evidence, and just changes in the overall environment that are really lovely in the way that they're incorporated into the shared principles. So now we're going to talk about each of the shared principles and give you a more concrete sense of what these 7 shared principles are.
Great, and I think I'm going to take us through that, but you know, I'd welcome you guys as we show them on the screen. I'm not going to tell you every single detail in there. I'm going to try to give you the kind of boiled down essence, but there's a lot of nuance in these principles that I don't want to lose. So we'll let you look at them on the screen while I walk through them, and I just welcome you guys to chat in any questions or observations you have, so we can have a little bit of interactivity. So the first principle is about person and family centered. And this, I think Anne is right, and she just said it. This is about whole person care, whether that's, you know, psychologically or emotionally, even spiritually. And it's also about being able to shape the design and the operation of care. Sorry, we got a little echo there. Typically, we often think about only engaging patients in their care. And one of the things that you'll see over and over again throughout multiple principles, not just in the person and family-centered principle, is this idea of patients and families as partners in care, but also in redesign and even in governance. So that was, I think, a relatively newer development. So we talked in this principle, the shared principles talk about care delivery being customized based on individual strengths. And also family and care partners being involved in decision-making, as well as I described in the operations. So the next principle is around continuous. And we had a lot of discussion in the steering committee. Glenn, did you want to chime in? I see you.
Yeah, just on the person and family aspect, you know, as a practicing physician, you know, I think even folks that have been involved in organizational leadership, either at the professional organization level or delivery system level, often think that we know what patient-centered is, but the honest truth is we don't. Until you ask patients for their input, you really can't validate that that you understand and are responding in a patient-centered way. And so this is one of the most key points to me in the 7 principles. It's one of the things that my project is encouraging practices to include. Our goal and recommendation to all primary care practices that they have a feedback mechanism from patients, and that would depend on the size. It might be a formal patient advisory council. It might be feedback by some smaller format. But the idea is to, as you said, Christine, engage the patients in the continual refinement of the care that they're receiving, because they're the most important person in the whole process.
Awesome, love it. So going to the next principle around continuous, and Anne, I think you're controlling the slides.
Yep.
So we talked in this principle a lot at the steering committee level around what is a dynamic and enduring relationship over time. The clinician knows me and remembers me, the care team knows me and remembers me. And so that idea of dynamicism, trusted, respect, and relationship over time was really critical here. And that relationship over time really provides an important perspective and context to the individual and their care. So that was a good addition that I think Ted Epperly came up with the perspective and context notion, and that was a really important contribution. So comprehensive and equity, unless Glenn, did you want to weigh in on that one?
Just on that one briefly, the thing that I liked that it highlighted, and I know you really nuanced the wording of this, I know it went through multiple iterations because I saw many of them, but this one about calling out the importance of caregivers, and they may not always be family, is just really huge in the care that people get now with chronic illnesses and more patients at home with chronic illnesses. I see a lot of my patients who their caregiver, who is not a blood or married relative to them in any way, is often the most important person of their life, in their life, and needs to be incorporated into this process. So I like how that was called out.
Great. So we talked also about comprehensive and equitable. So when you put person and family centeredness together with this continuous relationship, we heard a lot of input from a lot of you guys that we needed to be able to support that whole person continuous care with the appropriate range of clinical and supportive services. And there's a large list included here. And the danger with lists is always that you're going to leave somebody out. And so definitely did not mean for this list to be all inclusive. That's hence the and more on the end. But it shows the breadth of services that people told us primary care practices need to figure out how to arrange for. It didn't mean that every single practice has to have all of these services on site. There was a tremendous recognition that practices are different in different parts of the country, differently resourced, differently structured. So, but it did mean that the practices would need to give thought to and decide how to provide or coordinate these services across the spectrum of care. This principle is also really important because it tremendously, in my mind, elevated the idea of equity. Really put it at a principal level, and asks providers to really seek out the impact of social determinants of health and societal inequities. And we are grateful to Becca Etz and her team at VCU Health for helping to shape this particular language, and specifically given her expertise. But that we're delivering and tailoring care with those things in mind, and we're partnering with health and community-based organizations to make inequities visible and address them. So this was a very action-oriented principle, in my mind, that added something really new over previous sets. Glenn, any comment?
Yeah, I liked in your opening comments, Christine, about how you talked about these being both achievable and aspirational, and I think it applies right here as much as anywhere, especially my colleagues, as was mentioned in my introduction. My practice career started in a town of 2,700 and a practice of 3 physicians, 12 miles from a hospital. I know what it's like to be in a small practice, and it's daunting to look at this list as an expectation, but it is aspirational, and it is at least something that should be considered even in small practices, even if they can't have it all under their own roof. If they want to aspire to meet the full, comprehensive, and equitable related needs of their patients and community in a small town, that's especially a factor. The community aspect is that at least this is a reference for them to look to and aspire to.
So the next principle is team-based and collaborative. There's a lot in this one in particular here. So this is about, so I'm going to give you just a couple keywords out of the first sentence alone. Interdisciplinary teams, including patients and families, are working both collaboratively and dynamically toward a common goal. So we had a lot of discussion. We heard a lot of input from people that the notion of interdisciplinary was important, and that the team always has to include at the center individuals and their families, and that there's something that the teams, if they are able to work dynamically, I think Dr. Holly suggested that word, if they're able to work together dynamically, then not only are they coordinating, but they're building something that is inherently more synergistic and therefore contributing something larger than just, working together as, as individuals, right? So that idea of dynamically and synergistically was helpful. This principle also talks about people trained to work together at the top of their skill set and trained in things like leadership skills, as well as how to partner with individuals and their families. Again, not just in their care, but in the way we shape and design or co-create the practice operations, the way we evaluate the practice together based on their priorities and their needs. So that kind of skills-based training as well as training. Glenn, comments?
Yeah, I think this is a really important one as well, Christine. I think it's another area where if you ask physicians, they'll say they know what it's like to be team-based, and they don't always, because it isn't how they were trained. And I really like Atul Gawande's article about cowboys and pit crews. And we need to reach all the way back in the chain of educating, again, not just physicians, but other important members of this healthcare team, train them in a collaborative team-based environment, and they will know how to then practice in that environment, and they will be part of the dissemination of innovation of this piece that is really so important. I in 35 years of practice, I've learned a lot from people who didn't have MD or DO after their name, but they were really expert at what they did. Nurses, nurse practitioners, physician assistants, pharmacists, diabetic educators, physical therapists, and that list is not meant to be exhaustive either, Christine, because it's a really long one. But there's just so many people, if we open our mind, that we can learn from to our own benefit, but then engage their, as you said, dynamic and collaborative input to the care of our patients, which is at the end of the day what the physician wants the most, the best care for their patient.
Yeah, and this is why I love giving, being able to really give the flavor for each of these shared principles with you, Glenn, in collaboration as a physician. I think from a consumer viewpoint, oftentimes the team-based care doesn't come across as team-based to us, right? Because we experience care as, you go in and you see this person, and then the next person comes in the room, doesn't really appear that they've talked to the person before, we're not really sure, So I think the idea that we're blending the skills and the training on how to do real team-based and collaborative care with input from patients and families about how that team-based care is being experienced by them and how satisfying it is for the team itself. I think that sort of two-way combination is really important here. So the next principle is coordinated and integrated. We had a lot of discussion on this principle, and it was important for people. We had a lot of input in the surveys and in conversations with people from all of the many. And the idea of how to describe the kind of coordination and integration in the right way was something that was important. So we where the input we received really focused on this idea of integrating, that it's not just coordinating, but it's also integrating, and that sort of sense-making role that I think is really unique to primary care. So it involves proactive communication across the spectrum of care and collaborators, helping people to navigate the system, really providing that seamless care experience. But I think this component is tremendously unique to primary care, that integrating function and navigating and sense making, as I said. Glenn, I'd love to hear what you have to think about this.
Yeah, thanks. My phone dropped and I just got back on. Can you hear me?
Yes,
Yeah.
we can.
Okay, great. I just dialed back in, so I'm sorry. I missed what you said, Christine. Help me.
Well, I just was going through this particular principle, but also noting that it was really important. We got a lot of feedback to really get this one right, because people felt like it was somehow more than just coordination, but it was also this integration idea, which I think is really unique and specific to primary care. This idea that clinicians are in a point of making sense and helping people navigate, and so that sense-making role was something that I felt was important to that seamless care delivery experience across the lifespan that this principle talks about.
Yeah, thanks, Christine. You know, I think this need for integration and coordination is increasingly now and in the future even more so going to become important because of the complexity in our healthcare environment. And you know, that we have more and more high-tech treatments and medications and imaging, and yet the patient really needs a point of access to get the best possible care, and in some ways actually help them filter what they're being recommended to have done based on that, as you said earlier, the continuous piece, that long-term continuous relationship where you know that patient, their medical care, but also their preferences and their values, because there isn't one right answer in many cases for healthcare. It's more what's right for that person. And so being able to be there to do that coordination and help them in shared decision-making, and then to integrate it in any number of ways. Often integrated primary care is a term used to describe the inclusion of behavioral health, which is extremely important, but integration into other aspects of care. And the one I see most neglected just because of the construct of our healthcare system is oral health, which we know is so incredibly important and yet so often neglected.
And Judy Haber is somewhere clapping for you, and I couldn't agree more. And I think that it's related to this concept also of accessible, which is our next principle. And we talked a lot about access being both virtual but also in person, and this idea of readily accessible for all people, and access having, there being barriers to access that come in different forms, right? So there you go, Ann. So whether that is a language or literacy or socioeconomic access, cognitive, physical barriers. So we talked a lot about access being one of the hallmarks of primary care. First source of care, Barbara Starfield's 4Cs, first contact. So this idea also, though, that access is equally about responsiveness as well. And that was an important, I think, input that we received based on, what patients and their families need. And people asked us, well, does this mean that primary care practitioners control access to all the other specialists and elements of our healthcare system? And the answer was very plainly, absolutely not. We, I think, learned our lesson about asking primary care practitioners to be in a gatekeeper role, and we talked instead, and we specifically used this word, gateway, to high value care and community resources. And that's, again, kind of related to that integrator, sense-making, coordinated, proactive, nature, to me is very connected to this idea of access. And then we also talked about accessing our health information, that this is now not a special thing that you should have to make a request under HIPAA to get, your health data. This should really be easy, routine. Part of doing business with each other is that patients are able to easily access and take their health information with them where and when they need it. So Glenn, your thoughts?
Yeah, thanks. Not much I can add to that, Christine, and I know we're starting to run short on time. I think this list is very inclusive. We need to have practices that have extended hours. There's a tension there between maintaining practice satisfaction and life balance with our clinicians, and yet there are solutions to doing that. The technology piece, I have an informatics degree. I love tech, but we need to make sure that as we implement technology in practice, that we don't actually worsen equity by only reaching those people that have computer access or computer literate. We need to be conscious of how we do that. And I liked your comment. One of my most abhorrent terms in practice is gatekeeper. I'm a Northwest guy. I've been in California for 4 years. I consider myself to my patients a wilderness guide. The healthcare system is a wilderness, and you need somebody who has your back and can guide you through it. And that's my role, not gatekeeper.
I like that imagery.
So the last principle is about high value, and this really was, I felt, in the discussion reflective of the fact that people wanted the PCMH moniker to become a real indicator of high performance, high value, something that is a great, trustable moniker, if you will. So this was about actually achieving excellent, equitable outcomes, using healthcare resources wisely, having a systematic method for really measuring what I think amounts to performance in different dimensions. You can see them here, including equity. And then importantly, the ability to deliver exceptionally positive experiences, not just for patients and families, which when we think about experience often is limited to that realm, but also for staff and clinicians. And so the idea that this is a rewarding experience for everyone to both receive care, but also to deliver care and be part of that care ecosystem was really important for a lot of people.
Yeah, I agree. I think this is a good list as well. I look at it just very briefly as making sure that people get the care that they need and benefit from. And again, a big part of my role is making sure people don't get care that potentially is harmful and wasteful and doesn't contribute to their health.
So Anne, we'll turn it back.
Yeah. Thanks so much, Christine and Glenn, for going through the 7 shared principles. Now we're going to think a little bit about how do we put these principles into action. And as you know, as you've listened to these principles, many practices across the country are already implementing some of these principles, and in some places more than one, many of these principles. But how do we make this the standard, and how do we spread this vision? And so really, it's really turning back to all of you to think about what can you do to advance the shared principles. We here at the PCPCC will be doing many things, and we'll discuss that in a moment, but really ask you all to reflect on what you might do. And Glenn, you might want to just reflect a little bit from either the practice or the educational standpoint on what you think organizations might do.
Yeah, thanks, Anne. When Christine was talking about the team-based collaborative care, and I made the comment about how that really needs to be embedded in training and therefore will evolve into practice, I think this is absolutely true for these principles as well. The more that we can get these embraced and implemented by our medical education system, again, not just for physicians, but across all the clinicians that work in a primary care environment, so that these are the values that are embedded in them in the course of their training, then they can help also be sort of that dissemination. And then again, I look at this as not just our professional organizations who are signing on supporting these principles, but our individual, for me, clinical delivery organizations. It might be a small practice, it might be a hospital system, it might be an integrated delivery system, but the more that we see systems sign up and say, yes, we believe in these values, we're going to implement them into the culture of our organization, that will really help us build momentum.
I think that's really well said, Glenn. So I would say, what can everybody on the phone do? Well, if you're not signed on, go to pcpcc.org/sign and get signed on. You've now had a pretty detailed overview of them, so I hope you'll see the terrific value that 250 other people have signed on to. So the other thing I would say, though, is that our intention was that organizations, by virtue of signing on, would begin to build it into their strategic priorities. So, for example, we have 3 accrediting organizations signed on. And so the idea is that they will take these and operationalize aspects of them into their programs. We have payers signed on and purchasers. So the idea is that they will take them and build them into the work that they're doing to align payment so that we can really accelerate the realization of these principles. And then, to Anne's point, she just said it, there are aspects of these principles that are operational already. So sharing best practices around how people are making this happen in reality so that others can replicate that, I think is going to be really important. And then, I'm sure that there are also some barriers in public policy. And so helping PCPCC and others to identify those policy barriers and collectively come together and advocate for change. That's another way to advance these shared principles.
You actually anticipated this next question. So comments from either of you, and I'm happy to weigh in as well.
Well, I would start. Mine is not a federal advocacy organization, and yet, our goal was to build this shared voice, and I'm very appreciative of the process that's been shepherded along by people we've already thanked, and I'm going to thank one more that we forgot. I've been personally very grateful for Marcy Nielsen's investment in this, and Ann Greiner's, but there was a real potential that could have get dropped in the interim between. And so Rosie Sweeney, who served as in the interim role for the PCPCC, really made sure for all of us that this didn't drop. So thanks to Rosie as well. But I really do think that we're at the point where once we build this sign-on, organizations, whether they're professional organizations, clinical delivery organizations, but as you said, Christine, it may be purchasers, it may be employers. This is about those people, not about just exclusively the healthcare system. It's about what care do people want to receive, what kind of care do people want to purchase. And so once we get to that sort of critical mass, my hope is we turn that collective voice into power for change, and really build the primary care foundation our country needs.
And the community has proven that it can do this, take an abstract set of principles and get them into policy, and a whole care delivery model, which was the patient-centered medical home. And so now I think the question is, how do we think about translating this into a care delivery model? What are the implications for payment? How do we leverage accreditation to help in rolling this out? What is the role of employers? Because they signed the check after all, and what are they looking for? And employers were very important 10 years ago when the PCPCC started, because IBM said, we can't purchase the kind of primary care we want. And when you show employers this description, this is what they want. And then we got to work with the health plans and the physician groups and the nursing groups and everybody else to get us there. So I think there's a whole lot of opportunity here. We will be putting out our policy agenda in February of 2018, and it will be very much along the lines of a set of policy priorities that help us achieve the vision that's in the shared principles. So next question, I think I've really answered that in terms of our policy agenda. So last question, and then we're going to open it up for really comments and from everybody on the line. Christine, you alluded to this earlier, and I want to make sure that everyone knows that we're really looking for organizations to sign on, because I think we look for that collective agreement that this is how we want to move things forward. It's great to have individuals, but it really is the organizations that are going to make the change. And so you can go to our website, pcpcc.org/sign-on, and it's very easy to do. You can look at the 250 organizations that have already signed on and take the list of like organizations to whoever needs to approve something like that. And please do join us, because we have an exciting number of years ahead of us to try to achieve this vision. So we're now really opening it up for comments and questions. And as you do that, we do have a couple of polling questions that we'd like to ask in our remaining couple of minutes. So Lauren, maybe you can put those polling questions up as people start to ask questions, and we do have some.
Should we start with the sign-ons or the other one?
Sign-on, just so we get a sense of who's on there. So if those on the phone can sign on, answer these polling questions just so we know where people are?
Interesting results. We'll show them in a minute.
Okay. Wow, it just shows you've got lots of opportunity for people who are just learning about the shared principles to sign on. So that's great. And we've got 27% that have already signed on, and 11% that are looking at them. So a whole 60% of you can now have that opportunity to sign on. So that's great. How about the next quick poll?
At pcpcc.org/sign, not sign on. So if you go there right now.
Sorry.
Go into it. Might want to read the question out for people, Ann.
Are you willing to be a part of future advocacy efforts around the shared principles? Yes, I can't wait. Yes, I think so. And the last response, that depends.
Very interesting. Should spark good discussion.
Well, terrific. I think we've got a whole lot of folks that are interested, and we will certainly be putting the word out as we get our advocacy agenda off the ground, and seeking your assistance to move it forward. And for those of you in the that depends category, I'm sure once we're underway, we'll convince you to get involved. So thank you for that. We did get a couple of questions in, and let me just read them out. The first one really is for Glenn. How can family medicine, how can students of family medicine that are interested engage with your work to sustain this mission? From Judy Gary.
Yeah, thanks. So the website for our organization is fmahealth.org. And you can go look at the work of our engagement team, which is where this information and the work of the team that Ted Epperly led, that collaborated with the PCPCC. If people are interested in learning more and maybe being part of this activity, to the email address info@fmahealth.org, there's an email drop box where you can sign up, receive information. But if you're a medical student, my suggestion is to take this list of shared principles to your department chair in your Department of Family Medicine, or to the dean, or however high up the chain you feel comfortable going. And because we're really looking for medical education organizations to sign on to this. I'm very proud to say my undergraduate and medical school alma mater, University of Washington, has signed on to the shared principles of primary care, in due no small part the results of Ted Epperly.
Nice. We have really support from departments of family medicine across the country. They were probably the #1 source of multiple and repeated sign-on. So take a look too at the website, see if your Department of Family Medicine has signed on already. You guys really did a fabulous job organizing them, but I think that's such a good suggestion, Glenn, to take it back to the departments.
Excellent.
Thanks.
Next question is from Maricela Moreno. I hope I've pronounced her name correctly. Are there examples to reference of implementation occurring within FQHCs?
And I think you had speakers at the PCPCC conference who were good examples of that, right?
I'm trying to remember we do. In fact, we gave an award to Dr. Bryce, who is a DO, for his work at FQHC in Detroit, where they have really integrated an approach to addressing social determinants of health, nutrition, and exercise. And they are writing prescriptions for healthy food, and then they have a whole farmer's market right there on the clinic grounds. So the doc writes the prescription, and then the patient is then able to purchase the healthy foods that they need right there. And they also have embraced a lot of exercise programs in the community. So we do have some examples. I think, you know, we're really, these were just promulgated in October. As we build these out and have tools and examples of what practices are doing, our website will become more and more rich. So thank you for that question. Here's a question from Sharon DeMario. She's interested in hearing what the role of academic health centers, colleges of medicine, nursing, pharmacy, and allied health should be. You want to take that one, Glenn?
Yeah, I think they need to sign on and, as I said, infuse this into their organization. If you're in an academic health center, as opposed to, say, a single specialty residency program, you have the opportunity to embed these principles in a broader extent of health professionals and really get to this key piece we talked about collaborative team-based care. I think if each specialty, each discipline, each clinical discipline tries to do this in a silo, we will not get to the goal that we're really seeking. And so we need to, in our organizations, just as we did in the development of these, share these values and put them into action.
Well, I think that's a great note to end on, which is basically the way we're going to achieve success is through collaboration in every realm, whether it's team-based policy and advocacy, or trying to change health professions education. Whatever realm we're talking about, we really need that collaboration across stakeholder groups to be successful. So thank you so much, Christine and Glenn, for your leadership to bring these shared principles to fruition, and for all of the folks that you named prior who have been such important contributors. We're very excited to be launching these, and stay tuned for lots of work ahead, and we will be back in touch. Thank you.
Thanks,
Thanks, everyone.